Okay. Well, everybody, thank you for your patience. We had some technical issues getting this going. Welcome to the Youth Special Interest Group seminar today. And it's my pleasure to have two colleagues and fellow child psychiatrists amongst us to present on a rather important area of the confluence between cannabis and suicide. The first among them is Dr. Chris Hammond. He's an associate professor of psychiatry and pediatrics at the Johns Hopkins University School of Medicine. He directs the CODA clinic, which is co-occurring disorders in adolescents and young adults, as well as the research programs, and co-directs the care prevention and early prevention clinic there. His talk is going to be on results of a study that used 20 years of national mortality data to examine the impact of medical and recreational cannabis legalizations on suicide-related mortality amongst adolescents. Joining him and complementing his talk is Dr. Jesse Hinckley, who is an assistant clinical professor in the Division of Addiction Research, Treatment and Prevention within the Department of Psychiatry at the University of Colorado School of Medicine. And Dr. Hinckley will be presenting data from a secondary analysis of the NCS, the National Comorbidity Survey, the Adolescent Supplement. And this includes ages 13 to 18, and he will explore the association between cannabis use, major depression, and suicidal behavior. So with no further ado, off to Dr. Chris Hammond. Take it away.
All right. Apologies to everyone. Jesse is going to be sharing my slides and advancing them along forward, since I'm connecting via my telephone due to some technical difficulties here. Jesse,
it looks like as the new ones haven't made it through the firewall yet. I can bring up the ones I have and switch over
sure.
when I get them. Does that work?
That works, yeah.
Okay, I'll keep an eye out for them. Although I do need the ability to share my screen.
Should be all set.
Okay. All right. So thank you so much, Geetha, for the invitation to come and present some of my team's work and some of the sort of parallel work that Jesse and his team are doing, focused on this important area of cannabis use and suicide in young people. I'm going to be talking today about results from a study focusing on examining associations between state cannabis laws and suicide mortality among U.S. youth. Jesse, can you advance the slide forward? So I have no conflicts of interest related to this, and this slide just shows my disclosures. I receive grant funding from the NIH, from PCORI, and from some other sources. Can you advance? Okay, so this shows an outline of sort of thematically what I'm going to cover over the next about 20 to 25 minutes. I'm going to sort of provide sort of a big picture background on really sort of how cannabis policies and really the cannabis landscape has changed in the United States, and why we, those of us who do research in this space, are concerned that U.S. youth may represent a vulnerable subgroup related to cannabis legalization. And then I'm going to present the results from a study focused on state cannabis laws and their relationship to suicide-related outcomes using national mortality data. And then lastly, I'm going to touch on some future directions in research and some of the implications of the study in this space. So I think we've all probably experienced it and seen it both in our regular lives, but also those of us who are clinicians in our healthcare practice. The cannabis landscape in America has really changed rapidly and dramatically over the past 2 decades with shifts in state cannabis laws and legal availability, commercialization, changing products and potency, and really shifting societal attitudes, beliefs, and behaviors, all of which really carry health implications for American youth. Can you? This slide shows the changes in cannabis legalization that have really occurred over the past 28 years, from 1995, when California passed the first ballot initiative making cannabis for medical purposes legal, to today. There's been a dramatic shift in state cannabis legalization and availability. This slide shows really sort of the current state medical and recreational cannabis legalization framework, with this one actually being slightly outdated from about 1.5 years ago. But as of today, 39 states and the District of Columbia have enacted medical cannabis laws, and 24 states in the District of Columbia have enacted recreational cannabis laws, with nearly half of Americans currently living in a state or a jurisdiction where recreational cannabis is legal. In addition to these state law changes, there have also been changes in federal legislation and regulations related to cannabinoids in the US. The federal government has really played sort of a non-interference approach related to state cannabis legalization. And that really continued until about 2018, when the federal government passed the U.S. Agricultural Improvement Act, commonly known as the 2018 Farm Bill, which legalized and deregulated the growth, interstate transport, and sale of hemp-derived ingredients containing less than 0.3% Delta-9 THC, and removed these ingredients from the Schedule I list. In doing so, this bill really served as a catalyst that ignited the CBD supplement and hemp market, and also created a legal loophole for products containing synthetic hemp-derived THC and THC analogs, such as HD9, Delta-8, and Delta-10, to be marketed and sold as legal highs. There are current changes that are in the works with regard to upcoming potential legislation, including a potential rescheduling of cannabis from 1 to 3 under the Controlled Substances Act, and also a bill that's currently in the House of Representatives that is seeking to amend the Farm Bill and ban synthetic THC analogs. And so this space continues to change. Next slide. Amidst these legal and regulatory changes over the past 15 years, really there's emerged a multi-billion-dollar cannabis industry with mass commercialization. And really what we've seen over the past 20 years is really sort of a medicalization in how people think about cannabis, an increase in cannabis accessibility, broad cannabis advertising, social media promotion and marketing, and lobbying and legislative efforts. The US cannabis market is currently estimated at $15.8 billion, and the hemp product market is at $2.8 billion itself, both expected to grow dramatically over the next decade. Next slide. Amidst this legal deregulation and legalization, we've seen just a huge expansion in the types of cannabis products and the routes of administration, really as a result of technology put to bear on how people grow and use cannabinoids. Now cannabis products are much stronger than they were 10 and 15 years ago, and this carries significant health implications for U.S. youth who have experienced an increase in using cannabis through vaping, through dabbing, and an increased consumption of edible cannabis products. The average THC potency or concentration of both illicit cannabis samples, as shown in this slide, but also of legal cannabis in the medical market, have shown dramatic increases in delta-9 THC potency, tripling really over the past 20 years, with the rates of CBD concentrations showing a less consistent pattern and not really increasing at the same amount. This has led Nora Volkow, the director of the National Institute on Drug Abuse, to report that daily cannabis use today can have a stronger effect on the developing teen brain than it did 10 or 20 years ago. Next slide. These changes, both in cannabis laws and in the cannabis landscape, have really occurred both concurrent with and also driven societal changes in attitudes about cannabis, perceptions about the harms, and also potential health benefits of cannabis and use patterns of cannabis among U.S. adults and also adolescents. This slide from a Gallup poll from 2023 shows that the majority of American adults believe that cannabis should be legal for recreational use, and that rates of having tried cannabis and using cannabis regularly are increasing among U.S. adults, including adults with children or teens in the household. Next slide. And so within this context, there's really growing evidence that suggests that adolescents and young adults may represent a vulnerable subgroup that's more likely to experience negative outcomes related to changing cannabis policies. This is really supported by really 3 lines of evidence. Next. First, cannabis use and related problems are more common in this age group. Cannabis is the main federally illicit drug used by U.S. adolescents, and rates and methods of use have changed in the past decade, including increases in vaping and dabbing among U.S. adolescents, and also increases in past year, past month, and daily cannabis use, which are at or near historic highs in young adults and college students. Next slide. My research team recently published a meta-analysis aggregating studies that examined whether recreational or medical cannabis laws impacted youth cannabis use. And the results of this meta-analysis found that recreational cannabis legalization, but not medical cannabis legalization, is associated with increased past month cannabis use in both adolescents and young adults. The second line of evidence suggesting that adolescents are vulnerable are really preclinical and human neuroimaging studies pointing to a developmental sensitivity to cannabis exposure. Adolescents and young adults' brains undergo rapid maturation between the ages of 5 and 25, with an imbalance in reward and cognitive control systems really peaking during adolescence and making those youth more likely to use cannabis, to develop cannabis problems, and also making them more vulnerable to cannabis exposure. The third line of evidence comes from results from longitudinal studies, and meta-analyses, which have consistently shown that adolescent onset cannabis use is associated often in a dose-dependent fashion with adverse psychosocial outcomes across domains, including poorer outcomes academically, occupationally, impaired cognition, and a higher likelihood of developing both psychiatric and substance use problems by adulthood. In contrast, adult onset cannabis users may experience fewer adverse effects, and this really highlights the importance of prevention or sort of delaying the onset of cannabis use as a potential strategy to mitigate risk. Suicide is one of those outcomes that is particularly salient and important. Suicide is both a major public health crisis for U.S. youth and is associated with cannabis use. Rates of suicide, suicidal ideations, attempts, and deaths have increased among U.S. youth and have been exacerbated by the COVID-19 pandemic. And cannabis is associated with increased risk for suicidal ideations and non-fatal suicide attempts. These associations show dose-response relationships based upon cannabis exposure variables. And adolescent cannabis use is also associated with increased risk for psychiatric conditions that are associated with an increased suicidal risk as well. And so really in the context of this, U.S. adolescents being a risk population, an at-risk population for cannabis-related adverse outcomes and having higher suicide outcomes, we sought to examine associations between state medical and recreational cannabis laws and suicide risk, and sought to answer two research questions. One is, do state medical and recreational cannabis laws play a role in the increasing prevalence of suicide-related outcomes in U.S. youth? And then, do these associations vary as a function of age and sex and race and ethnicity? And to really study this, we examined national mortality files obtained from the National Vital Statistics System from the years 2000 to 2019. And so from these files, we focused on youth ages 12 to 25 who had died by suicide between 2000 and 2019 and stratified that into 5 different age groups. The main measure that we used to identify subjects was documented suicide deaths according to ICD-9 and ICD-10 cause of death codes. Our main exposure variable for our analyses was time-varying cannabis law status based on year and month of effective date. Next slide. Oh yeah, sorry. For our data analysis, we applied what's called a staggered adoption difference in difference approach that applies really a regression modeling to determine associations between medical cannabis laws, recreational cannabis laws, and suicide rates, while controlling for individual and state level covariates and accounting for varying effective dates of medical cannabis law and recreational cannabis law onset by state. The primary outcome variable was incident rate ratios of suicide deaths as a function of state cannabis law status. And this approach, this sort of difference in difference and difference in difference like approaches really are the gold standard for drug policy and health policy studies in this space. Next slide. I'm not going to go into detail here, but this slide shows the covariates. We covariated for multiple individual and state level covariates as part of the analysis. Next slide. We also conducted 4 sensitivity analyses to determine if the effects related to, if associations between state cannabis laws and suicide could be accounted for by other factors, such as state mental health expenditures. Next slide. This slide shows our results for unadjusted suicide deaths from the study. We found that between 2000 and 2019, 113,512 young people in the US died by suicide. That's a sobering statistic. And we found that the average unadjusted annual suicide death rate for US youth was 10.9 per 100,000 young people. Our unadjusted analyses, unadjusted suicide rates differed as a function of both sex, age, and state cannabis law status, with the table on the right showing variation as a function of state cannabis law status. As you can see, youth living in states without cannabis laws had the lowest suicide death rates, and states in medical cannabis law only states had middle death rates, and then those living in recreational cannabis law states had the highest death rate. So this seems to point to sort of stepwise differences as a function of state cannabis laws. Next slide. This slide shows these unadjusted deaths by suicide among female youth on the left and male youth on the right, calculated at every age and really stratified by state cannabis law status. Again, showing that sort of stepwise difference from no cannabis laws to medical cannabis only laws to recreational cannabis laws. Next slide. In our multivariate regression models, a main effect for cannabis laws on suicide was not seen, but interaction effects for sex by cannabis law and age by sex by cannabis law on suicide rates were observed. Specifically, these analyses seem to suggest that the association between cannabis laws and suicide are varying as a function of sex and age. Next slide. And so this table shows the incident rate ratios indexing covariate adjusted suicide deaths related to state cannabis laws in US youth stratified by sex and age group, with female cases at the top and male cases at the bottom, and significant findings shown in bold. Can you click next? Okay, so as highlighted in green here, female youth across age groups had higher covariate adjusted suicide rates related to state cannabis laws, and a significant main effect of sex was seen in analyses collapsing across age groups, showing that female youth living in states with recreational cannabis laws had a 16% higher suicide rate, and female youth living in medical cannabis law states having a 10% higher suicide rate than their female counterparts living in states with no cannabis laws. In contrast, for males, the results were less precise, and our sensitivity analyses showed really variable and inconsistent results, which were mostly non-significant, suggesting that suicide rates and cannabis laws were largely unrelated in that subgroup. Next slide. This slide shows suicide death rates related to state cannabis laws in US youth collapsed across all sexes or genders and stratified by age group. And if you click the highlighted significant results in the green box, there was a significant age by cannabis law effect for youth in the 14 to 16-year-old age band, showing that youth age 14 to 16 years old living in states with recreational cannabis laws had 9% and 14% higher rates of covariate adjusted suicide deaths compared to their 14 to 16-year-old counterparts from states with medical cannabis laws and no cannabis laws, respectively. Given that racial disparities, particularly in cannabis-related arrests, are prominent and may impact psychosocial outcomes, and that there are racial and ethnic differences in both cannabis use patterns among youth and suicide patterns among youth. In a follow-up analysis, we sought to examine if these cannabis law, suicide, mortality outcomes varied as a function of race and ethnicity. And we conducted sort of parallel analyses to our main sex and age analyses and found significant race and ethnicity by cannabis law effects. These analyses found that the race by cannabis law effects were driven by a significant difference in Asian youth, whereby Asian youth living in states with medical and recreational cannabis laws had higher suicide death rates compared to Asian youth living in states without cannabis laws. And our ethnicity by cannabis law effects showed that Hispanic or Latinx youth living in states with recreational cannabis laws had increased suicide deaths compared to Hispanic youth living in states with medical cannabis or no cannabis laws. And we found that the differences in suicide deaths as a function of cannabis law status for non-Hispanic Black, non-Hispanic White, and Native American youth were non-significant. And so this slide really shows a summary of the larger study findings here. We found that medical and recreational cannabis legalization was associated with increased suicide-related mortality in female youth and in Asian youth in the US. And we found that recreational cannabis legalization was associated with increased suicide-related mortality in 14 to 16-year-olds, regardless of their gender or sex, and in Hispanic or Latinx US youth. These results seem to indicate modest effect sizes, like 10 to 16% for the sex effects. But at the population level, this translates to nearly 5,000 excess deaths by suicide in female youth related to state cannabis legalization in the 20-year period studied. The mechanisms through which these cannabis policies are related to increased youth suicide, particularly for these different subgroups, warrants further study and should inform legislative reform. Next slide. This slide really shows the strengths, limitations, and future research directions. So this study had a number of strengths. It's a large population-wide sample, recruiting individuals from all 50 states and DC over a 20-year period, and focused on documented suicides from national death records and vulnerable population. And our findings were robust to covariate adjustment and sensitivity analyses. The limitation for this, and for actually most policy-focused large-scale studies, is really the ecological design. And so this requires further replication and sort of independent individual-level analyses. Future research directions, my group and others are really focused on trying to understand what might be driving this association by looking at individual level factors such as psychiatric conditions, treatment utilization, psychosocial, psychotropic medication prescription, and parent cannabis use and parenting, and also looking at the variation or heterogeneity in both medical and recreational cannabis laws, and if specific provisions such as like THC limits may impact these outcomes. And lastly, looking at cannabis market characteristics and how regulatory enforcement might impact these outcomes. Last slide, yeah. This slide just shows some study implications that I think are common to both my work and the work that Jesse is going to present. There's really an increased need for suicide screening and prevention in U.S. youth amidst this youth mental health crisis in America. And this may be particularly important for youth who use cannabis or have cannabis use disorders. And the need for suicide prevention in young people really may be greater in medical cannabis law and recreational cannabis law states. While more research is really needed in the treatment, prevention, and early intervention space, the idea that cannabis prevention, early intervention, and effective treatment may serve as really a suicide risk reduction is something that really warrants further study and may be recommended. And then really at the population health level, really, there needs to be public health messaging, provider education, and workforce training, and sort of guides to recommend how providers have discussions with young people and their parents about cannabis use and the relationship between cannabis use and suicide risk. And these discussions and this messaging and education really needs to take into account changing societal beliefs about cannabis's safety, harms, and benefits that have really been fostered or driven by this growing for-profit cannabis industry that's begun to use techniques learned from big tobacco and big alcohol industries. And so I'll end there. Thank you.
Thank you so much, Chris. I'm looking at the time, it's 11:35, so we have two options. We can take a very quick 1 or 2 questions now and then turn it over to Jesse, or we could have Jesse present and then open up for questions at the end. I'm open to either option.
I think if someone has a burning question, dive on in.
I believe you have to either raise your hand using reactions or type it into the Q&A, which then would be visible to the panelists, and we will read it out loud. So either way is fine. Well, we see someone with a question.
Yeah, Nomita, you should be able to unmute now.
Hi, can you hear me?
Yes.
Hi, good morning. Excellent presentation. Thank you very much. I'm an internal medicine, addiction medicine doc, pivoting back to education, research, and community health. I am curious about your findings with regards to stratification by age, and then further stratification by male versus female, and then substratification by age. And that most of the substratified age groups for males didn't show statistical significance except for one. But when you did the all ages in males, there is some statistical significance. And as you mentioned, lots more studies and adjustment for different variables could be done, mental health, socioeconomics. Any thoughts preliminarily on why females had such more marked statistical significance in terms of correlation as opposed to male, based on what you found?
So my team has some hypotheses related to that, and we're currently starting to investigate them. There's perhaps like 15 to 20 years of literature that seem to show that that male and females who use cannabis, that females who use cannabis experience different subjective effects and have higher rates of co-occurring depression and anxiety and internalizing conditions, and are more likely to experience withdrawal symptoms than males, and that may also experience different sort of environmental factors that may precede cannabis initiation. And so we wonder if there's an effect related to that. That is, if this effect is mediated through co-occurring mood and anxiety disorders in female youth. But I think that more work needs to be done in that space, and I think that examining sex differences related to cannabis use and cannabis outcomes, I think, is an important avenue that really sort of warrants further study in general across different types of analyses.
Thank you.
Mm-hmm.
Thank you. All right, so let's hand it over to Jesse Hinckley next. Jesse, it's all yours.
All right, everybody. Thank you for being here, and thank you to Geeta for the invitation to present to you all today. I have to remember when I speak with the good Dr. Hammond that I need to dress up. but I often don't travel with a suit and tie, so I apologize. But I wanted to follow up with that and talk a little bit more specifically about looking at the association of cannabis use with depression severity and suicidality. This was a secondary analysis of the National Comorbidity Survey-Adolescent Supplement. In terms of disclosures, still not very interesting, but certainly slightly more chaotic than they were the last time I presented. And so things are definitely changing. This is the group that I worked with on this analysis and that I work with on other projects, and grateful for their support. So as you know, major depressive disorder is common during adolescence. Cannabis, as Chris talked about, is the most commonly used substance during adolescence, illicit substance. And the association of cannabis with depression, severity, and suicidal behavior during adolescence, there are sprinklings in the literature that there's an association, but there's not really a definitive, this is the association. And so this was something that we wanted to look at, particularly in the context of a lot of patients who will push back when you try and talk about this association by saying, well, cannabis is the only thing that helps me sleep, or it's the only thing that helps me feel better. So we really wanted to investigate the prevalence of major depressive disorder and major depressive episodes in adolescents with cannabis use, and then explore the association with cannabis use and major depression with suicidal behavior. The National Comorbidity Survey-Adolescent Supplement consisted of roughly 10,000 youth done in the early 2000s. This was an epidemiologic study. It was designed to look at factors associated with the onset of mental health disorders in youth. And so it's very rich in terms of its covariates and in terms of its phenotyping of mental health disorders and mental health problems in youth. The one limitation with any given, one of the challenges of doing this type of work in these surveys is they aren't really written by people or designed by people who specifically are interested in substance use. And then the substance use surveys are not really designed by people who are interested in comorbid disorders necessarily. And so either you end up with a paucity of variables related to mental health, or a paucity of variables related to substance use. It's a challenge to find an ideal data set. But within this data set, cannabis use was queried as having ever used, and then past 12-month use, as well as frequency, which we converted into a categorical variable. Depression was categorized as major depressive disorder with severity, which was a hierarchical design that included some level of impairment, as well as past 12-month major depressive episode with severity, and then in addition, lifetime and past 12-month suicidal behavior. And so overall, what you see here, those that used cannabis were slightly older than those who did not, which you would expect. Otherwise, you can see here that there were some differences that we incorporated as sociodemographic variables with the covariates within the model. When we look at the prevalence of depression in those who use cannabis and those who did not, you can see here that the prevalence of depression by severity is slightly higher in those that use cannabis. So looking at then the odds ratios between these, what we did is we did an ordinal regression, and this was looking at, oh, sorry, it's jumping on me. Ordinal regression looking at the depression in relation to cannabis use. And so this is corrected or incorporates all of these different covariates that you can see here on the y-axis, and then the odds ratio is log-based and presented on the x-axis. What you can see here, so this is looking at youth who use cannabis that have mild to moderate depression compared to those who do not use cannabis. And the odds ratios of having mild to moderate depression was about 2 times higher, a little over 2 times higher in those that use cannabis compared to those that don't. For severe depression, it was about 3.3 times higher in those that use cannabis compared to those who don't. And so we can see here that not only is it associated with higher prevalence of major depressive disorder in those who use cannabis, but the severity also was. One of the other things we wanted to look into in this particular study was, are there associations between specific depression-related symptoms and cannabis use? And so what we did is we looked at the different symptoms of depression within individuals that have depression, and divided again by those who do not use cannabis and those who had. And there were only two symptoms that really showed any statistical significant difference. One was appetite problems, and the other was suicidal ideation and suicide attempt. But other symptom domains did not show any significant differences between these two groups. So as we looked at lifetime cannabis use and major depression and its association with lifetime suicide attempt, again, what we did here was a regression that would incorporate all of these different factors, this time also incorporating major depression and cannabis within the same model as covariates. And what you can see here in this, again, following the same setup with the variables on the y-axis, the log-based odds ratios on the x-axis, is that for cannabis use itself, the odds of having a suicide attempt after adjusting for whether or not they had depression was about 6.9 times higher in those who used cannabis than those who did not. So that's incorporating the effects of depression. Similarly, after adjusting for whether or not they used cannabis, if they had mild to moderate depression, the odds of having a suicide attempt was 4.1 times higher than if they did not have depression. And for severe depression, the odds were about 14 times higher than if they did not have depression. And so in this model, we were able to kind of look at cannabis while also considering whether or not they had depression, and similarly looking at the effect of depression accounting for their cannabis use. So that's one of the limitations of these studies is that's lifetime use, lifetime depression, lifetime severity. The closest we could get in terms of proximal effect was to look at past 12-month use and past 12-month mental health, including major depressive episodes, as well as suicide attempts. I didn't show you the data in terms of the correlation between the association between cannabis use and past 12-month major depressive episode, but it's similar to what we saw for lifetime use. But in this model here, this is again similar to the previous model. So it's looking at suicide attempt as the primary outcome, again adjusting for the sociodemographic variables as well as cannabis use and major depressive episode by severity within the model. And what you can see here is that when modeling past 12-month suicide attempt, for those who had cannabis use after adjusting for depression, their odds of having a suicide attempt in the past 12 months was about 3.7 times higher than those who did not use cannabis. As would kind of make sense with a more proximal analysis, depression seemed to have a larger role in the likelihood of having a suicide attempt. And so after adjusting for cannabis use, those with mild to moderate depression had 7.9 times higher odds compared to those that don't. And those that had severe depression had a 36 times higher odds than those who do not have severe depression after adjusting for their cannabis use. One of the other lines of evidence that we wanted to look at, because specifically within the past 12-month data, was, well, is there any association between the frequency at which they use cannabis and whether or not they have depression or whether or not they have suicidal behavior, kind of in a way of looking at is there some sort of dose response effect as another potential line of evidence into this association. What you can see here is that overall, specifically when we look at severe major depressive episode, using at least 1 to 3 days a month, so kind of what we would consider regular use in adolescence, kind of if you use 1 day a month as kind of that cutoff, using regularly in adolescence is associated with higher odds of having severe depression. For mild to moderate depression, 3 to 4 days a week or more. And so really the bigger association was here in the severe depression, which kind of gets to what Chris was talking about, is some of this relationship between cannabis and suicide. Is it mediated by mental health problems such as severe depression? When we specifically looked at past 12-month suicidal behavior, so this table is broken down by suicidal ideation, suicide attempt, and suicide plan and suicide attempt. We'll focus on the bottom panel here of suicide attempt, which obviously is the worst outcome that we can have with youth with suicidal behavior. And so you can see here less than monthly, 1 to 3 days per month, up to 1 to 2 days per week, and 3 to 4 days per week or more. And you can see that stepwise increase in the adjusted odds ratio of likelihood of having a suicide attempt as their frequency of cannabis use goes up within this population. So overall, when we looked at this study, cannabis use was associated with higher odds of lifetime major depressive disorder, past 12-month major depressive episode, and depression severity. Both cannabis use and major depressive disorder or major depressive episode are independently associated with higher odds of lifetime and past 12-month suicidal behavior, including suicide attempt. And more frequent cannabis use is associated with higher odds of suicide attempt in the past 12 months. And so all of that data, multiple lines of analyses from the same data set support a similar conclusion that there is an association between cannabis and both depression and suicidal behavior. Other studies that have also shown cross-sectional and longitudinal associations between cannabis use and depression or suicidal behavior. Actually, Chris and I are currently working on a systematic review and meta-analysis looking at cannabis use and suicidal behavior in youth. So hopefully, fingers crossed, we'll be able to see that to fruition and across the finish line. But when we think about what is the relationship, when you look at especially epidemiologic studies, there's a bidirectional relationship between cannabis use and depression. One component of that may be what is colloquially referred to as the self-medication hypothesis, which I definitely run into a lot with youth, where they talk about how cannabis is the one thing that helps them feel better or feel different. Cannabis is also associated with increased odds of developing depression later in life. And so not all cases are depression comes first and I use cannabis. There are also genetic factors and shared neurobiologic etiology of both cannabis use disorder and depressive disorder, as well as other mental health disorders. However, the potential mechanisms between cannabis use and suicidal behaviors are not well understood. And from a policy perspective, when we think about all of this and the implications that it has, obviously, as legalization of cannabis has spread, some states have done that with fairly minimal oversight and regulation initially, which has kind of led to these natural experiments that allow certain studies to be done. However, to get good, rigorous data because of how cannabis is classified and the types of stigma around studying it or the lack of perceived need has made it challenging to really make definitive statements. In the past, we've used animal models a lot to look at the association of substance use with certain outcomes or neurobiology. And even though I think that is really valuable, and one of my collaborators, Yasmin Hurd, does fabulous animal work. One of the things I've really learned in collaborating with her is the phenotypic part of it. There are some real limitations. A lot of the animal models turn out probably to be closer to trauma models or stress-induced models than maybe other factors that might cause mental health like depression. And so, there's definitely a lot of multidisciplinary work that needs to be done to try and figure this out, but it's definitely some real challenges and limitations that I think we as a field have not yet figured out how to overcome. But thank you again for being here and for humoring me as I shared these findings with you.